Hello and welcome to Navigating with Hen podcast station. Today we will have Dr. Tom Evans here to help us understand the primary care provider role in hospital quality. Dr. Evans is president and CEO of the Iowa Healthcare Collaborative. He practiced family medicine for 13 years and he served as chief medical officer for the Iowa Health System. Dr. Evans has served on the board for the National Patient Safety Foundation and on the delegations for both the American Medical Association and the American Academy of Family Physicians. He is a nationally recognized speaker on leadership, medication safety, and patient and family engagement. Dr. Evans has served as president of both the Iowa Medical Society and the Iowa Academy of Family Physicians. He is also a faculty member with the Institute of Healthcare Improvement in the College of Medicine at the Des Moines University and College of Public Health at the University of Iowa. Well, Dr. Evans, thank you for joining us and taking the time out of your busy schedule to have a conversation today around hospital leadership engagement to drive quality. So today I'm going to ask you to focus around some of our HIN measures that are primarily practitioner-driven, and some of those measures are truly provider-driven, as we know. The measures are from our IPOP or claims-based data. Some of those measures include postoperative pulmonary embolism, deep vein thrombosis, the radiology measures, readmissions. And Dr. Evans, really what I'm looking for today is how can the quality leaders in our hospitals improve provider engagement when improvement opportunities are identified for provider-led measures?
Thanks, Lana. It's really good to be here today. When we were kind of talking about this topic, I really would kind of summarize it as really focused on how do we engage our providers as activated partners with us as we move our enterprise forward. So we have, as I understand it, this podcast has mostly hospital quality leaders, and that's really who my audience is that I'm going to be addressing. So with regard to your first question about how can we, how can quality directors and leads improve provider engagement with our work and kind of driving some of our measures, there are two things that really kind of stick in my brain. One of them is you have to remember where they are at this point. And your medical staff who are all working in this volume-based healthcare system, and they realize it's moving to a value-based healthcare system. But in the volume-based healthcare system, it's all about the provider. It's all about how many widgets we can generate. It's all about how many patients I can see in a day or how many surgeries I can do. And it becomes a provider-centric system, which is fine, and they're used to it, and they've been in that, and that's what we've all been dealing with. But I think it's really clear that as we move to a value-based system, now it moves from how many widgets we generate to how effective our care is. And it's going to take all of us to be participating in making our care more effective. The reason I'm going here is we're moving from a provider-centric system under volume to a patient-centered system in value. If we can't engage our patients as activated partners with us in their care, there are going to be more screw-ups. There's going to be more inefficiency. So I think trying to have discussions with your medical staff about the shift from discussions about patient-centered care, about patient-centric care, design of the care around the patient is a powerful place to go. So I would be talking with my medical staff about patient-centered care. Number two, I would be talking to my medical staff about harm reduction. Remember that harm reduction and patient safety is about eliminating unintended consequences of care. And I think it's important sometimes you may need to realize or remind your medical staff that as we eliminate harm, as we improve patient safety, there will be fewer malpractice cases. And their malpractice exposure actually decreases by doing better care and focusing on harm reduction. So again, I think two keys to engage our medical staff would be focusing on patient-centered care and engaging our patients as activated partners and on reducing harm.
Our HIN hospitals, many are focusing on the readmission work, as we all are with the CMS initiatives to work on readmissions. Dr. Evans, what would be some strategies that you could recommend to get providers focused on reducing readmissions with our partnership for patient goal in reducing?
Boy, this is a big one. reducing readmissions is I think most people know it's a national goal. And let's just call a spade a spade. Nobody wants to be in the hospital. If someone is broken, they would prefer to be broken at home rather than being in the hospital. Now, the interesting thing is, we are trying to get people out of the hospital and keep them from bouncing back too often. I think it's important for us to think about what a readmission is. Readmissions are really just a metric. Really, readmissions are a measure of the process of coordinating care coordination. So a readmission is a failure of care coordination. That's what CMS is measuring. How often did we not prepare someone to be successful when they go home? So I think the way to reduce readmissions is to be focusing on good care transitions. And when I think, this is just me, but when I think about good care transitions from one venue to another, I like to ask 4 questions. The first one would be, is this patient going home to a secure environment? Are there social determinants of health or other factors that make them unable to have a sustainable situation when they go home? So, number 1, are they going home to a secure environment? Number 2, are they personally capable? Sometimes we have people who aren't. Now, we have to ask the question, A, are they capable, or B, are their family members capable to help them? And that's just kind of the nuance. But besides secure environment, is the patient even capable of being successful in an outpatient arena? I like to ask number 3. After I've thought the first 2 through, the third question, and then now it's my job to make sure that they are prepared to go home. So are they prepared? Have we equipped them with the skills, the knowledge, the medications? Do they know how to use what they need to use? All of that stuff. Basically, have we educated them to the point where they can be successful when they go home? Now, if they're going home to a secure environment and they're capable and they're prepared, the last question I like to ask is, and when is their follow-up? Because their follow-up should be scheduled sometime between 2 and 7 days, but we want to check back as quickly as we can to make sure, to gauge how successful we are in that transition. So again, I like to secure environment, capable, are they prepared, and is their follow-up scheduled? I think if we do these things, we can improve care transitions.
Great information, Dr. Evans. Thank you. I know that working toward a culture of engagement with patient safety focus has been a huge priority for most of our hospitals. If there were 3 areas that you could provide for our hospital quality leaders, what would they be when they're working with medical staff? Where could they focus?
People on the podcast can't see me smiling right now, but this is basically, how do I engage my doc as an activated partner? And they're busy and they're doing things, and it seems like I just irritate them some of the time. So how can we engage them? I guess I have kind of 2 clumps of thought. The first one is we have to remember that we're trying to build teams now going forward. So the first thought would be, you need to be affable, be their friend, you're trying to build a team here. So don't come in as the person who now is the keeper of the data and you're going to tell them how bad they are and they're going to see you in the other end of the hall and run. So find ways that you can be seen as their friend, their partner, the person who they are working with in the process of generating better care. So number 1, be affable. Now, the second piece I would say is, it's one thing to be affable. The second piece that I just remind you of is, I'm going to challenge you to be respectful. And I want you to be respectful in a couple of ways. Number 1, be respectful of harm reduction. I've mentioned in this earlier here that no one wants to have a patient safety event. And remember that if we do, there's a chance that they're going to get sued. So everyone wants patient safety. Your medical staff does, you do, your patients do. It's a wonderful aligning strategy. So be respectful of the whole topic of harm reduction and how it can be an aligning topic. Number 2, be respectful of their time and their attention span. Your physicians still are predominantly in a volume-based reimbursement world, and the only thing they can sell is their time for the most part. So you have to remember that time is money to them. They're busy, and so be thinking about, don't waste their time. Make sure that what you have, you're prepared, you got your act ready, and you bring it to them, and you give them something that they can react to. Don't make it a multi-step process. I have these 15 things we need to think about now. Make it so that they can sit here, process the information you have, and give you a decision and move on. remember, it's not only being respectful of their time, but also being respectful of their attention span. The longer your story goes, the more they're going to disengage. So be thinking about having it well prepared that you can move forward. Now, the last one is maybe a little hard to hear, but because now you're being respectful of harm reduction and being respectful of time, and now I'm going to tell you just to be respectful. Now, what does that mean? I want you to be respectful even when they are not. And there will be times when they're not. They're short, they're busy, they're doing things. I would encourage the quality leaders to model the behavior that you want to see. I know this sounds like a real golden rule thing, but the fact of the matter is we're moving into team-based care with value-based reimbursement, and the more we model what it means to operate effectively on a team, the better off we're going to be. So again, be respectful even when they are not.
Well, that's perfect. Relational development is huge with our team-based care. I'd like to thank everybody for joining us on this episode, and Dr. Evans, thank you so much for your time today. Please remember that the Iowa Healthcare Collaborative's Compass HIN team is here to assist you in your quality works. Feel free to reach out anytime.